Hello, my name is Sarah Burton, and today I'm going to present to you the 5 A's framework, an evidence-based intervention for managing obesity and weight loss counseling in the busy primary care setting. A little bit of background about this subject. Obesity is a persistent public health problem that frequently presents in primary care. Due to the vast impact obesity has on the health quality, medical cost, and life expectancy, reducing the prevalence of obesity has become a major public health priority. Recent updates on evidence-based treatment recommendations for preventable diseases indicate higher thresholds and parameters for primary care providers to initiate medication for management. Therefore, primary care providers are now accountable for addressing primary prevention and lifestyle modification interventions as the first step in many disease management treatment guidelines. The purpose of this video is to provide primary care providers with an easily accessible resource describing the implementation of an evidence-based behavioral therapy intervention, the 5 A's behavior change model, that creates a simple and practical strategy for obesity counseling in the primary care setting. Here are the learning objectives for the video. I want to be able to raise awareness about the seriousness of the obesity epidemic in our country, review current recommendations for the management of obesity in the primary care setting, discuss current practice barriers to obesity management in the primary care setting, help you become familiar with the 5 A's behavior change model, improve your ability to provide patient-focused care plans that will aid in obesity management, and teach you to connect patients to educational and community resources. Okay, first, let's start off by talking about the prevalence of obesity. More than 2/3 of the adults in our nation are either obese or overweight, and 1/3 of adults are obese. More than 1 in 12 children are obese during early childhood. That's 8.4%. And then by 12 to 19 years old, 20.9% of children become obese. And then you can see over to the left, the statistics are broken up into ethnicity groups. Obesity rates were highest among African American adults, followed by Latino and white adults, and the lowest rates are among Asian American adults. This is a chart showing overweight and obesity trends in U.S. adults from 1962 to 2010. Since the early 1960s, the prevalence of obesity among adults more than doubled, increasing from 13.4% to 35.7%. According to the National Center for Health Statistics, obesity prevalence remains mostly 34.7% stable from 1999 to 2010. But there was a slight increase. The problem with the slight increase is that it had significant statistics to it. The significant statistics were among men overall, as well as among African American women and Mexican American women. Obesity in the United is one of the main influences of preventable chronic diseases and healthcare costs in the United States. Obesity healthcare costs range from $147 billion to $210 billion every single year. Obesity-related work absenteeism accounts for about $4.3 billion a year. According to the 2015 annual report, the State of Obesity, Better Policies for America, on the current trajectory that we're going on right now, by 2030, combined medical costs related to treating preventable obesity-related diseases are estimated to increase by between $48 billion and $66 billion every single year. The loss of economic productivity annually could range anywhere from between $309 billion and $580 billion. With these increasing healthcare costs and dwindling resources, these statistics are why obesity has become a national epidemic and critical public health concern. So it is well known that obesity is associated with high morbidity and mortality rates. The World Health Organization estimates that globally, overweight and obesity are the fifth leading cause of death. That being said, an increase in BMI is a major risk factor for non-communicable diseases such as type 2 diabetes, or glucose intolerance, cardiovascular diseases, hypertension, and even some types of cancer. As your BMI rises, so does the risk factor for these comorbidities. Some risk factors to the left are listed that are risk factors for obesity: high blood pressure, high cholesterol, high blood glucose, family history of premature heart disease, physical inactivity, and cigarette smoking. In a systemic review done in 2010 by Lynn O'Connor, Whitlock, and Bell, counseling to improve diet or increase physical activity changed health behaviors and was associated with small improvements in adiposity, blood pressure, and lipid levels. All of that being said, here's the problem that we face. Despite the United States Preventative Services Task Force recommendations and multiple professional practice guidelines on the management of obesity in primary care, the identification and treatment rate of obesity still remains low. There is very little research evidence on the effectiveness of current primary care obesity management. The most recent studies have found that only 18% of obese patients receive counseling for weight loss. So, what's the deal? Why, over the past 13 years, has it been so difficult to implement this evidence into practice? So, the next slide shows all of the barriers that primary care providers and patients have to deal with currently when going through obesity management. So, for providers, some of the main barriers are a lack of training in counseling techniques. A lot of studies show that providers don't feel like they got enough education in school or haven't had enough experience with treating obesity. Another barrier is provider weight bias, and that comes down to oftentimes providers don't understand how much their patients really do want to change. It has to do with judging obesity as being lazy. The next barrier is in the past there's been issues with a lack of reimbursement and an incentive to even do these services on top of taking care of all the acute issues that the patient has. Another barrier is sometimes providers are skeptic to believe that behavior change interventions can make a difference in specific health outcomes. That being said, not all behaviors are considered equal to providers in terms of intervening or in the provider's willingness to intervene. An example of that would be a provider may give patients smoking cessation education more often because he or she is more comfortable with the counseling. It's more straightforward, as well as the fact evidence shows that counseling is more effective than any other type of counseling. Also, if a provider is not confident in the counseling that he's giving, he or she is not gonna feel confident enough to provide the patient with information because they don't really have they don't feel like they have a lot to give them because they don't really know what to do in terms of a plan of care. The next one is huge. A huge provider barrier is lack of time with patients. So time is the biggest obstacle that providers face when it comes to doing any type of primary prevention, but especially any type of behavioral counseling, because providers are forced to make choices about preventative service on a case-by-case basis. The patient's current problems usually take precedence over screening and counseling. Multiple agenda visits contribute to the time problem. Usually, studies show that providers handle at least 2 to 3 problems an encounter. Acute concerns crowd out all the chronic care management abilities and preventative measures that providers can give in that short amount of time. So the increase in complexity of chronic disease management added to that obesity's caused has added to the time restraint that providers have to be able to do everything for their patients. And then the last one, barrier for providers, is a lack of resources for referral and education. And that comes down to not really knowing the resources, living in rural towns and not having resources. Also, people who aren't reimbursed for counseling either. So those are huge for providers. For patient barriers, patients are treated with plans that are focused on isolated health issues rather than comprehensive health status. There's a lack of readiness for change oftentimes in patients, or they too are skeptical that behavior change will be of any type of benefit for them. Another barrier is self-efficacy to lose weight is not developed due to our current fragmented nature of traditional patient education. So we just tell patients what to do. We don't give them any type of self-management skills, so they don't have that confidence to take on things like weight loss. Another barrier is poor misunderstanding of advice. They may not really understand what they need to do, what little or how much they need to do in order to make health benefits. Just a little bit of increase in exercise may help their health status, when they're thinking they have to climb mountains. So poor misunderstanding of the advice is big for them. Also, lastly, for patient barriers, a lack of patient-provider collaboration, which we've kind of already talked about, and the time in visits time is spent trying to fight the fires, trying to get all the issues, listen to all the complaints. There's no time really to do any motivational interviewing and getting to know of patients. A large body of evidence supports the effectiveness of behavioral interventions for lowering the risk of developing chronic diseases, as well as for assisting in the management of existing diseases. As a result, national guidelines consistently emphasize lifestyle behavior interventions for the general health, as well as for most diseases or high-risk conditions. There are numerous types of guidelines, which may be a problem in itself, but I've listed the main overweight and obesity clinical practice guidelines and provided links for you to be able to click to get to these guidelines. So the U.S. Preventive Task Force Screening for Management of Obesity in Adults and the American College of Cardiology, American Heart Association, and the Obesity Society guidelines for management of overweight and obesity states for providers to screen BMI at least annually, if not more often, and to treat patients with a BMI greater than or equal to 30. They should treat them with comprehensive lifestyle or behavioral change interventions. Then the Endocrine Society, the Pharmacological Management of Obesity Clinical Practice Guideline, recommends that diet, exercise, and behavioral modification be included in all obesity management approaches for BMI greater than 25. Other therapies, such as pharmacotherapy for BMI greater than 27 with comorbidities, or a BMI greater than 30, and bariatric surgery for BMI greater than 35 with comorbidities or greater than 40. So here's some research on the evidence of behavioral change interventions in primary care. A recent systemic review conducted by LeBlanc, O'Connor, Whitlock, and Patnode in Kapaka showed that primary care-based behavioral interventions could result in modest weight loss of 6.6 pounds over a year, as well as prevent the development of hypertension and type 2 diabetes in at-risk patients. Research also shows that diets with exercise and or behavioral therapy yield significant reduction in hypertension and improvement in risk of metabolic syndrome and diabetes with no treatment control. The premier trial results suggest that training in use of behavioral strategies like self-monitoring are associated with improved health behaviors, which in return can lead to significant weight loss. When patients are counseled by healthcare providers to lose weight, they are more likely to attempt to lose weight, improve diet, and increase physical activity. That to me was huge because really all we have to do is counsel, and it statistically shows that they're going to be more likely to try and better their health. Okay, and there is a strong evidence base of support for the success in weight loss utilizing face-to-face counseling, but a growing literature suggests telephone-delivered counseling is generally just as effective. So more and more studies are coming out about the use of internet-based and telephone-based adjunct interventions to face-to-face interventions. Right now, though, the strongest evidence still shows that face-to-face counseling is the best option for yielding weight loss. A randomized controlled trials yield that behavior treatment trials providing 12 to 26 intervention sessions during the first year, patients lost 4 to 7 kilograms, an average of 6% of their baseline body weight at 12 to 18 months, compared to little to no weight loss in the control groups. Higher treatment intensity was associated with greater weight loss. That makes sense, despite limitations in our measure of treatment intensity. Most higher intensity interventions include self-monitoring, setting goals, addressing barriers to change, and strategizing about maintaining long-term changes. And these are all things that we can do quickly in a primary care setting for intensive behavioral change therapy. Patient-centeredness is endorsed by patients in the primary care setting and associated with increased patient satisfaction and health outcomes. Higher quality physician counseling may lead to increased motivation and intervention to lose weight. So, how counseling skills are delivered does matter, and that quality of the physician-patient relationship may actually have a big influence on patients' commitment to behavior change. So, long story short, the research shows that primary care-based behavioral change interventions and counseling can be effective in increasing the quality of health in obese patients. But due to the faults in our current fee-for-service acute healthcare style system and the fact that obesity is contributing to increased rates of chronic comorbidities, we as primary health care providers can only put out so many fires in one visit. In order to successfully make a paradigm shift in focusing healthcare on prevention and longevity, we while still providing the secondary prevention and tertiary treatment healthcare, providers need a universal, effective framework to guide behavior change interventions. That in itself is the purpose of the 5 A's framework. So, what are the 5 A's? Assess, advise, agree, assist, and arrange. The self-management model with 5 A's what the 5 A's framework is based off of, behavioral change model. This model guides healthcare providers in assessing risks and readiness to change, advising specific behavior changes, agreeing on specific goals in a collaborative manner, assisting patients in action plan by addressing barriers, which is an aspect of motivational interview, and arranging for follow-up or referring the patient for further treatment. According to the 2014 review on the models used for the weight loss counseling by Scherson, Jimenez, and Catalamas, the model's use as a tool utilized by primary care practitioners to encourage behavior change has been gaining momentum as an all-purpose counseling model that can be used in multidisciplinary care to produce many types of behavior changes. So the 5 A's model was first developed as the 4 A's model. It was ask, advise, assist, and arrange. This model was developed by the National Cancer Institute to guide providers in helping patients stop smoking. Noting the model's success through high-quality controlled trials in tobacco cessation reported by the U.S. Public Health Services, who used the A's framework to report on many trials conducted in primary care settings to test brief, feasible, population-level interventions, the Canadian Task Force of Preventative Health Care added a 5th A, and it was agree. And they have utilized the model to organize their general approach to counseling patients with behavioral issues. So there's a side note. In evidence-based literature, there are several modifications of the 5 A's framework that is recommended for the use in primary care. So there is the Canadian Obesity Network, their tool, the 5 A's of Obesity Management Toolkit. It is ask, assess, advise, assist, and arrange. And then there's also a new recently published review article that suggests a modified 5 A's for obesity counseling in primary care. And that is ask, assess, advise, agree, and assist. So the version that is referred by the U.S. Preventative Service Task Force is the assess, advise, agree, assist, and arrange version. And for the remainder of this PowerPoint in our education, we will use the 5 A's referenced by the task force. And really and honestly, the only difference is the first step, which is assess in the task force version. And under assess in their version, the first thing that they do is ask. So I think that the main thing is just making sure to ask using the motivational interviewing skills, ask the patient and start the conversation if they would like to talk about their weight gain. So, the research evidence of primary care use of 5 A's behavioral change model. We'll talk a little bit about research-based evidence. So, there was a systemic review by Whitlock, Orlins, Pender, and Allen in 2002 that evaluated primary care behavioral counseling interventions. This review found there was strong evidence that the 5 A's model adapted from tobacco cessation interventions in clinical care can also be effective in helping patients modify their health behavior and promoting physical activity. The use of a universal approach to behavioral counseling techniques may lend familiarity and efficacy to primary care provider counseling. Behavior change theories and models from the social and behavioral sciences explain the biological, cognitive, behavioral, and psychosocial environmental determinants of health-related behaviors. They also define interventions to produce changes in knowledge, attitudes, motivation, self-confidence, skills, and social supports required for behavior change and maintenance. Receiving little or no training on the 5 A's for discussing obesity, an observational analysis study conducted by Alexander and colleagues in 2011, consisting of a large sample size, studied The effectiveness of the 5As in weight loss counseling resulted in evidence that physicians were already using at least some portion of the technique in most encounters with overweight or obese patients. So the study found that physicians were more likely to ask the patient about weight, nutrition, or exercise and advise, but rarely assess patients' readiness for change, assist, or arrange. The emphasis on advise is not a surprise due to physicians are trained on information giving and seeking, ask and advise, and are less trained in partnership building type behaviors. But only utilizing ask and advise enables the providers to be in a situation where they can't learn what patients are actually willing to do and therefore cannot help formulate an action plan for change. The study also showed that physicians were found to use more of the 5As with heavier patients and more motivated patients. So therefore, physicians are more likely to do more for those in need of more help and for those they think may have the biggest impact on. These are motivated patients. Studies also show that physicians are reluctant to counsel patients who do not want to change, which sounds like human nature to me. The use of the 5As influence patients in becoming more motivated to change, more confident to change, and therefore more likely to change. Physician use of assisted or arranged showed improvements in actual dietary fat intake scores. That was a change in one fat-related eating behavior. The only 5A that was singly linked to actual weight loss in this particular study was arrange. That stresses the importance of the follow-up in behavior change counseling. Patients whose providers arranged a follow-up visit were more likely to have lost weight 3 months following the visit. Frequency of contact is important with elements for influencing behavior change. Patients are shown to have feelings of accountability to their physicians. Research suggests that the implementation of the 5A's obesity management, which is a obesity management tool based on the 5A's behavior change model that was developed by the Canadian Obesity Network for Primary Care Providers, facilitates weight management in primary care by promoting physician-patient communications, medical assessment for obesity, and plans for follow-up care. The intervention also is a framework that incorporates conceptual structure of the best practices in obesity management in a stepwise approach. According to Scherzen, Jimenez, and Catalanos, the majority of overweight or obese patients are not informed by primary care providers that they are overweight. The ones who are simply told or assessed are almost 9 times more likely to perceive their weight as damaging to their health compared to those who are not informed. So just telling a patient that their BMI is 30 and they are obese will actually help them perceive the damage that their weight is doing to their body. The 5A's behavior change model is the approach to counseling recommended by the U.S. Preventive Services Task Force. In following their recommendations, the Centers for Medicare and Medicaid also use the framework as a practice standard for primary care providers. The U.S. Preventive Services Task Force chose to adopt the 5A's model because it was judged to have the highest degree of empirical support for each of the elements and because of its use in existing literature. In 2003, the USPSTF recommended PCPs screen all adults for obesity and offer intensive behavior counseling to affected patients either by providing treatment themselves or by referral. The Centers for Medicare and Medicaid Services states that their coverage for intensive behavioral therapy and counseling interventions for obesity should be consistent with the 5A's framework. In 2011, the CMS approved primary care provided intensive behavioral weight loss counseling for obese beneficiaries when delivered by physicians and other CMS-defined primary providers. This was a huge step in increasing the amount of preventative care in primary practice when Medicare started reimbursing providers for actually making visits and encounters that are focused on behavioral counseling and not just acute needs of the patient. So the primary care use of 5A's behavioral model change for Medicare. So Medicare beneficiaries are diagnosed with obesity whose counseling is furnished by a qualified primary care physician or other primary care practitioner in a primary care setting. CMS will cover one face-to-face visit a week for the very first month, then one face-to-face visit every other week for months 2 through 6. Now, at month 6 visit, to be eligible for additional face-to-face visits once a month for an additional 6 months, the patient must have lost at least 3 kilograms the first 6 months of therapy. This weight loss also, in order to be reimbursed, it must be documented in the patient's MHR. If the patient did lose at least 3 kilograms, they can go on and have one face-to-face visit every month for months 7 through 12. On this slide, I also provided the ICD-10 and CPT codes used for this intervention. And then I put a link on this slide that will take you to the Centers for Medicare and Medicaid Services provider educational page if you have any questions about how to provide this care for your Medicare beneficiaries. So, given its evidence-based success in behavior change counseling for weight loss and its recommended use by national guidelines, I wanted to provide you all with continued education on what the 5A's framework is, how to use it, and how to implement it into practice in order to use it as a tool to provide high-quality obesity management in the primary care setting. As we go through each of the A's, I have provided you all with references and practice resources needed to use the framework successfully. So, what are the 5 A's? The first one is assess. You want to assess the patient about their beliefs, behavior, and knowledge about current weight. And then the second A is advise. You want to provide specific information about health risks and benefits of change. The third A is agree. You want to collaboratively set goals based on patients' interests and confidence in their ability to lose weight. The fourth A is assist. Identify patient barriers, strategies, problem-solving techniques, and social and environmental support for the patient. And then the last A is arrange. Specify a plan for follow-up because like we read in the research earlier, follow-up is really important in being successful in behavioral change. So I'm going to start with assess. So the things that you want to assess are their risk assessment. You want to assess for comorbidities. You want to assess their current behaviors and the root causes. You want to assess their history of weight loss and their stage of readiness for change. So under assess, you want to first assess or ask patients if they would like to discuss their weight. It is important to ask the patient if they want to discuss their weight because it opens up dialogue for the conversation as well as is a way to use motivational interviewing and open-ended questioning. So you may ask the patient, may I talk to you about your weight? Next, you'll want to ask and assess about behavioral health risks. That may sound like, how do you feel about your current weight? What you do for exercise. Thirdly, you'll want to ask about weight, nutrition, and or physical activity habits. One of those questions may sound like, how important is it for you to work on your weight? Then you'll want to assess the severity of their obesity by measuring their body mass index, waist circumference, and staging their obesity. So you may talk to the patient in this form. BMI is 32, which is considered stage 1 obesity. So remember how important it was to tell the patient about their obesity. That's one of the factors that will help them in motivation. Then you'll want to assess complications of excess fat, which would be comorbidities, and you'll also want to look at psychosocial factors. And then at the same time, you want to explore the root causes of the weight gain. So that may sound like, did you ever have issues overeating before you were diagnosed with depression? So the first step in assess is you want to calculate the body mass index. You'll want to do that by either using the formula I provided, or I have a link on this slide that you can click for the National Institute of Health Body Mass Index Calculator. And as you know, there are many of those out there and many apps on your phone that you can use quickly to calculate your patient's BMI. Once you have calculated the BMI, any BMI greater than 30 is classified as obesity, and there are 3 classes of obesity depending on the severity. Many guidelines and recommendations also state the importance of utilizing waist circumference to assess truncal obesity, which is a known indicator for high risk of metabolic complications such as type 2 diabetes and cardiovascular disease. Waist circumference cutoff points help to identify those that are at increased health risk within the normal weight, overweight, and class 1 obese BMI categories. So just because someone doesn't have a BMI of 30 does not mean that they are increased to have negative metabolic complications due to their health. So that's where this waist circumference comes in, and I have a chart that shows from the World Health Organization website that shows cutoff points and the type of risk they are in for each point. The Edmonton Obesity Staging System is a good tool to quickly assess overall health-related risks. To sum up this slide, ask yourself if you are worried at all about the patient's metabolic, mechanical, or emotional status. So, is there anything that takes priority due to the need for testing or treatment before even thinking about weight loss? Also, what comorbidities, conditions must you simultaneously treat as you provide weight loss management? So here's another chart just to help. I'm trying to give you multiple resources, and that way you can find things that fit best for your way of practice. But the National Institute of Health also has a chart that shows the classification of overweight and obesity by BMI, waist circumference, and associated disease risks. So next, you want to assess obesity risks and severity. You want to go through and assess for the drivers, complications, and barriers of obesity. So the Canadian Obesity Network came up with the 4 M's of obesity, and it has proven to be a great way for primary care providers to quickly assess the complications and barriers in obesity management. The first M stands for mental health. Not only can common mental health problems lead to weight gain, but when present, they can make weight management much more challenging. In addition, excess weight can directly affect mental health by promoting poor self-esteem, depression, and social anxiety disorder. So devising a weight management plan always requires a good understanding of your patient's mental health status, if only to determine there's a need. Indeed, no major mental health causes or consequences of weight gain or significant mental health barriers that will make weight management difficult, not impossible, for you and your patient. The second M is a reminder to look for the many mechanical causes or complications of excess weight. When present, these issues can not only promote exacerbated weight gain, but can also pose important barriers to weight management. For example, if someone is in chronic pain, if they have knee pain or ankle pain, they're very unlikely to exercise at least 5 days a week, which is what's recommended. So you'll want to assess all of those barriers and treat those root problems. The third M should prompt providers to look for metabolic complications of excess weight. Often the presence of these conditions or the treatments we use to control these conditions can contribute to further weight gain rather than help solve problems. So we want to make sure and assess all the medications that patients are on, make sure that they're not on any medications that increase weight gain. Also, assess them for types of diagnoses that put them at increased risk for weight gain. Then the last M stands for money, which is a factor that can affect weight gain because eating out is very expensive, or it can pose an important barrier for weight management because not only is gaining weight expensive, but weight management costs time and money. So if patients' insurance do not cover provider counseling, it does cost a lot of money to go to programs or to go to dietitians. After a complete assessment of the patient's 4 M's, hopefully the provider is able to understand the likely causes and consequences of this patient's state of obesity and the potential barriers to its treatment, which are specific to each patient. The next part of assess will be to perform a brief nutrition assessment. You can do that by a multitude of different ways, but I listed 3 that I have found very helpful. The first one is the Rapid Eating Assessment for Patients, or REAP assessment tool. Along with that is the WAVE assessment tool, and then there's also one called Rate Your Plate. So I've given you the links. If you click on the box, the tool will come up. I've also given you a link to the Brown University's research tool and tools and resource page, and there are a lot of really great resources on this page. So for your assessment, the REAP assessment tool is a semi-quantitative food frequency questionnaire that directs patients to record eating problems and provides an assessment of the nutritional quality of the food choices. The tool has been validated and shown to be an effective part of a program to lower patients' cholesterol in primary care practice, work sites, and other community settings. So in the corner, you'll see I have a chart that shows how using the WAVE and REAP tool to conduct nutrition counseling, and you can do this in less than 10 minutes. So on the left side, if you however many minutes you have is what part of the intervention you do. So if you have 8 to 9 minutes, you can do the WAVE protocol, and you can do a whole 1-day recall where they write down their whole diet for a day. If you have 6 to 7 minutes, you can do the WAVE protocol with a self-assessment, which is the REAP. If you only have 3 to 5 minutes, you can just do the REAP assessment tool with goal setting. And then if they're walking out the door and you have 1 to 2 minutes, you can discuss the importance of nutrition and assess readiness to change, and give the patient the REAP tool to take home and set their own goals. Providing them with a handout and web resources or whatever. It'll give them something to think about, something to do. They'll have to look at it more than once to throw it away or get it in the house, whatever. At least in that 1 to 2 minutes, you've planted the seed and got the information out there. You'll also want to assess the patient's physical activity. You'll want to assess their current level of activity, noting the amount of sedentary activity. So the physical activity readiness questionnaire, better known as PAR-Q, is an easy, quick assessment that you can give to your patients, as well as the AHA American College of Sports Medicine Health Fitness Facility Pre-Participation Screening Guide. These are both tools that you can give to the patient when they check in, and they can go ahead and fill these out in the waiting room and have them filled out before coming into the encounter. that will help you save time, and y'all can use that talking about goals and setting goals in a plan of care instead of filling out the paperwork. So the American Heart Association and American College of Sports Medicine guidelines for exercise training and prescription are in the algorithm above. And if you go down the algorithm, it gives you, in the end, it gives you scenarios of patients who are at high risk, moderate risk, and low risk. So you can take that level. So not only can you figure out what type of risk your patient has for physical activity and endurance activity with their health care related problems, you can also follow the ACSM's guidelines for exercise testing and prescribing. It's the 9th edition, is brand new, and it states that on the slide the following information describes patients who should absolutely have exercise testing prior to obtaining an exercise prescription. So there's a lot of stuff on this slide, a lot going on. I wanted you to have it, but to sum everything up, individuals from the algorithm on the slide before that are at moderate risk with 2 or more cardiovascular disease risk factors, and individuals that are at high risk with symptoms or an actual diagnosis of cardiovascular disease. They all need to have a medical examination prior to initiating physical activity. Bottom line, if you ever question, just go ahead and do the full testing. And then also the ACSM has a chart for recommendation for exercise testing prior to exercise diagnosed cardiovascular disease. So on this chart, you can read the people who also need testing that you wouldn't just normally pick out. At the same time, I gave you a link for the ACSM guidelines. That way you can look these up yourself if you have questions or need a little bit more detail. This slide is a resource on the recommended lab test by the level of risk and clinical assessment, as well as a list of exercise contraindications. So the contraindications include unstable angina, aortic aneurysm, aortic stenosis that's severe, acute MI, active myocarditis, VTAC that's under control, multi-premature ventricular contractions, and a 2 kilogram or more increase in body mass over 1 to 3 days. So those are all absolute contraindications to physical activity until you've treated those healthcare risks. So here I have given you some examples of the PAR-Q. There are a few different kinds for different for specific patients. So there's an adult Spanish version. If the patient does not pass the first version, they will need to take the second screening version to narrow down, their issues and their problems. And then there's one for pregnancy, and then there's a quick PAR-Q that anybody can take, and it's effective results for their readiness for activity. So the next thing you'll need to assess is you'll need to ask the patient to score the perceived ability to make behavior change. Some important questions that you can ask are, on a scale of 1 to 10, how important is it to you to manage your weight at this time? On a scale of 1 to 10, how ready are you to manage your weight at this time? How confident are you that you can manage your weight without support at this time? And on a scale of 1 to 10, how confident are you that you can manage your weight with support? There are numerous studies that identify links between emotional confidence and a goal and the means of achieving it, and corresponding behaviors that support achievement of the goal, such as cooperative behaviors, motivated and supportive behaviors, a predisposition for adoption, and perseverance in the face of difficulty. Therefore, it's important to assess the patient's readiness for change. So the stages of readiness for change are pre-contemplation, contemplation, preparation, action, and maintenance. And you can assess patients to see where they are. And then there's also resources out there that give you interventions for what stage of readiness they are. So, it's a good idea to assess their readiness to change due to the fact that it does have a huge contribution as to the success of your interventions. So you'll also need to assess for the need of adjunct medical therapy. So I went ahead and put the Endocrine Society practice guidelines up on here. Again, there's the link. In that guideline, there is an algorithm that I've posted that helps you clinically decide if your patient needs to be managed with medicine along with behavioral therapy. So besides, giving medication or referring them to surgery, no matter what is needed for their treatment of obesity, behavioral interventions and self-management are key in being successful in any obese intervention. So no matter what, they need to go through behavioral counseling. I also put a link here for information on bariatric surgery for severe obesity so you can inform your patients on the need for surgery. All right, the next A is advise. You want to make sure to advise your patient on clear behavior changes, very specific for them. You want to make sure to personalize the behavior changes. You'll want to advise them on information on the health risks associated with their obesity, also health risks associated with exercising, or the health risks of not exercising. You'll want to continue and advise them about information for the health benefits of exercising, which way outweigh the risks of exercising. And then you'll go through and talk through patients about all the treatment plans, the options that they have, and they are able to decide what's best for them. All right, so specifically under advise, the first thing you'll want to do is make sure that you're giving clear, specific, and personalized behavior change advice. Under that includes personal health risks, their risk for diabetes, their risk for hypertension, and for cardiovascular diseases. The next thing is their benefit of modest weight loss. You need to make sure that they understand that just decreasing their sedentary behaviors will increase their health. And then also the last thing, you need to make sure they understand that, weight loss and treatment of obesity is definitely long-term and chronic. So a question that you may use or a statement that you may use in practice with your motivational interviewing skills would be, now that we have a better understanding of your situation, do you care if we explore and come up with a plan of action that improves things? So that's a good way just to get things going, but also just to get permission from them to keep going. So the next thing you'll want to do is identify the caloric deficit that they need to meet in order to lose weight. And you'll want to provide them information on all types of diets and the importance of not only sticking to the diet, but the importance of self-monitoring and how much that helps them stick to a diet. And a communication intervention would be the health risk of obesity, such as diabetes, high blood pressure, and cardiovascular disease can be reduced through increased exercise with or without weight loss. So just getting up and moving is helpful. And then on number 4, the thing that you'll need to do next with advise is take them on recommended nutrition guidelines regarding proportions, varieties, daily amounts, consuming less fat, sugar, and sodium. You'll want to stress the importance or educate them on how to read food labels in order to limit eating out. you can use the conversation starter as, I believe you will need to lose about 35 pounds to lower your cholesterol and blood pressure. If you do this, you may be able to avoid taking medication every day. So that's a really good way of being specific with their healthcare risk and the benefit that exercise can give them. So number 5, you'll want to highlight the importance of substituting low to moderate intensity physical activity for current sedentary activities. So in doing that, especially with very sedentary patients, you'll want to plan a stepwise increase in activity for previously sedentary patients. So you could say, here is a written prescription for an exercise plan that I would like you to follow until we meet again on our follow-up next week. And actually give them a piece of paper on a prescription pad. That is shown to be helpful, and they're more likely to follow your advice. And then number 6, you'll want to discuss and explore all treatment options. All the options are behavior change, therapy, medication, and surgery. And a conversation piece could be, since you are telling me about how your knees are hurting and keeping you from exercising, I suggest that you try low impact exercise like walking, biking, or swimming, and do it at least 5 days a week. And that highlights the importance of substituting even the littlest thing of what they can do at their level will help with their overall health. So the first thing that you'll want to make sure and cover, which also covers pretty much everything else in this section, is you'll want to advise on treatment options. So that includes educating the patient on overall treatment options and letting them decide what's best for them. That will make them definitely be more likely to be successful with the plan of care. So in order to lose weight, you'll want to advise your patients on getting enough sleep, what happens if they don't get enough sleep, time management, and stress management. Those are big deals with weight loss. You'll also want to go over all the different types of dietary interventions, such as low-calorie diets, high glycemic index diets, different types of diets that are out there. And go over all the information and help them pick out what's best for them and their health status. You'll want to advise them on the recommended physical activity. You'll want to talk with them and assess for psychological needs of referral and different ways that they can help themselves psychologically become more healthy. You'll want to go over low-calorie diets. Another treatment option is anti-obesity medications. So if they meet the guidelines and the need for adjunct therapy with your behavioral therapy, then there's definitely medications for that. And then also, if they are at the point where they need bariatric surgery. So those are all options that you can talk to them about, make them aware of, future possibilities, and that will help them have an overall idea of the plan of care that they need to agree with you on. So, under advise, you after you've gone over all your treatment options, I think that it's great to be able to lay something down, educate a patient on, they're going to be doing this hard work. What are the benefits that they are going to get? It takes time, it takes energy, it takes commitment. So, what are they actually getting from this? And so this chart right here that I put on this slide, it's a great reference. It is from the American College of Sports Medicine 2014 guidelines, and it lists the evidence of physical activity and positive health outcomes. So just putting that on their refrigerator could definitely be a great reminder that, exercising and being active is not just going to help them lose weight. It's going to help them become more healthy. It's going to help them decrease their risk for chronic diseases, more than just lose weight. So due to the fact that there are multitudes of different ways to advise patients on nutrition and giving them dietary counseling, I tried to make it as brief as I could in putting the Dietary Guidelines for Americans 2015 to 2020 link on this page. It has a multitude of educational resources for you as a provider, but also for your patients. and it is the most up-to-date guidelines actually could find on nutrition. There are other nutritional guidelines for obesity, but this one to me really seemed to encompass everything that you would need to teach your patients. So the big thing that I wanted to highlight under dietary counseling was I wanted to share with you the evidence-based nutrition advice for behavioral counseling. So this list in this box are things that have actually been researched and trials have been done, and they are actually successful in helping with weight loss in behavioral counseling. So the first is allowing the patient to self-select a diet after you've taught them about all the different diets. Give them a set calorie restriction. So once you figure out, how many calories they need to intake to be able to lose weight, with exercise, give them that prescription. You can also go over portion control with them. There are so many things wrong with the portions that our society thinks are normal. So, definitely going over the plate method with them, which we'll talk about in a few minutes. Then keeping a diet diary, that is huge. There's a lot of evidence-based research showing that people, especially at the beginning of their weight loss journey, are able to lose more weight if they keep a exercise and diet diary. Also stress eating breakfast. That's a big successful factor in weight loss and weight management. And then too, if you can refer them to a dietitian, if that is available to you, or if they are able to do that, that's a great idea, just to get some multidisciplinary action in there, as well as different types of education that we don't all think of the same things to educate our patients. So then too, you can do meal replacements, shakes, or NutriBullet type things, diet prescriptions. So writing down on a prescription pad the type of diet that they need. There are also commercial programs that research has proved. Actually, a 2004 research article proved that Weight Watchers, along with Jenny Craig, were the two most successful programs commercially. So if your patient asks about which program to go to, evidence-based wise, Weight Watchers is the best. You can give them patient handouts or resources online, which I'm going to give you a few of those in a little while, for them to go home and to think about these things and to really look things up on their own. Advocate for them to learn how to educate themselves on their health status. Also, you can give them community references. Hopefully your community has great resources, and if not, that's something else you can become a part of. But if you do, give them a list of those resources, just to give them something different to do and to help keep them motivated. Also, sample meals, just giving them a piece of paper that says on Monday do this, on Tuesday do this, has given people guidelines to abide by. You can also refer some self-help books if that's kind of their deal, and then along with that, multidisciplinary care is huge. So that's the great thing about the 5 A's framework, is that it's universal and we can use it across disciplines. So the dietitian and me both can use this and not start over with the patient. The patient is still right where the other person left off, as well as, personal trainers, same thing. You can do this same exact assessment, and the patient will benefit from each profession keeping on the same track. So that's the great thing about the 5 A's framework with nutrition counseling. So this slide covers the SERVE mnemonic, and this mnemonic provides primary care providers with a rapid assessment tool for habits that patients may need to change in order to be successful in weight loss and weight loss management. So this is a down and dirty way to remember when you're in the middle of talking about 10 different things with them and they throw in there that, they have this big wound on their foot or, whatever, you can still think serve as you're talking through nutrition education with them. So S is for you want to assess their use of sugar sweetened beverages and other liquid calories. If they are intaking a lot of those, they need to change that habit. Also, you can remember to assess their exercise habits. The R is for regularity of meals, especially breakfast, and the amount of times that they eat out at restaurants. Those are huge things, components that are needed for health maintenance as well. Research shows that patients who eat breakfast every day are healthier and maintain a more stable weight. And we all know that eating out is full of enormous portions and empty calories. So that's something you can quickly assess and kind of give a little education about. And then the V is for vegetables and fruit-rich diet. So there are actually initiatives out there that are national initiatives to increase fruit and vegetable intake. So, if your patient is in a bind where they're out and there's not a lot of healthy options, filling up with fruits and vegetables are always going to be a better choice. And the same being said for any type of diet choice. Increase your fruits and vegetables. So the E, eating less or proportion meal size awareness. Like I said, the U.S. society, we have a very dysfunctional view on proportions. So really just making sure that they understand, what an appropriate size portion is and the amounts that they need to get on a daily basis. So this serve mnemonic is a really easy and quick way to review your patient's nutrition status. Okay, so the next couple of slides are going to be about evidence-based interventions that are actually written in the guidelines and the type of evidence they are. So a level 2 evidence intervention would be to stress to your patient the importance of reading food labels in order to make healthier choices by choosing foods low in sodium, sugar, and fat. So just making sure that your patient understands how to read food labels and that they know the portions at the top, the serving size, they understand how to read them, but also that they know what on those labels are good for them and what is going to not be good for them. So we take for granted what common knowledge is when you're in the healthcare profession. So then level 3 advice would be to make sure and use recommendations from the Dietary Guidelines for Americans regarding proportion sizes, food variety, and limiting empty calories. So that goes back to using that link that I gave you earlier. Not only can you educate yourself if you have any any insecurities about your your knowledge base on current recommendations for nutrition, but also you can send your patients to this site and not have to worry, that they're reading false facts or that they're getting, wrong advice. So definitely use guidelines. And then another level 3 evidence intervention would be to educate your patients on limiting eating out at restaurants and to show them how to make healthy choices by eating more fruits and vegetables when they do go out to eat. This helps them avoid large portion sizes and the intake of absolutely low energy foods that are just going to make them hungry again. So, the fact that our society is built on go, 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 busy, busy, busy. A lot of people have no choice but to eat out sometimes. So just, educating them on limiting in this if they can, and then how to deal with that barrier if it is something that's going to keep them from losing weight. Okay, so here is the level of evidence for interventions about physical activity that are in the obesity guidelines. Number 1, the level 1 evidence. So, one of the most important things that if you can tell your patients anything, this proves to help with weight loss is providing obesity education and associated risks and educating on the fact that the risk can be reduced through increasing physical activity with or without weight loss. So just make sure your patients know any type of reduction in their sedentary activities, and turning that into physical activity is going to be helpful, whether they lose 1 pound or whether they gain a pound. If they are increasing their activity, they are helping their risks, and they're helping their health status. So making sure that they understand that. And then some level 3 advice to give your patients would be stress the importance of substituting sedentary activities with low to moderate intensity physical activity. And then make a gradual stepwise plan to increase activity for patients who were previously sedentary. So you don't want to overdo it. You don't want to make them, not ever want to do it again. So start with a 5 to 10 minute session, and then give them a plan to increase slowly to a physical activity goal. So that also will give them motivation as they meet their daily or weekly goals. That will keep them motivated to keep on exercising. Okay, so speaking of physical activity advice that's evidence-based, this next slide is got a whole lot going on, and I really meant it for it to be more of a resource for you all. But you'll want to advise your patient on the amounts and intensity of physical activity that is recommended in order for them to actually get benefits, health related benefits. So everything on this slide is from the U.S. Department of Health and Human Services, the Physical Activity Guidelines for Americans. So to the left in the red is the actual guidelines for adults. And then in the purple and orange, it kind of helps you and your patients to understand what moderate intensity examples of exercise would be, also, and what vigorously intensive exercises would be, because I think that everybody probably has their own definition for those words. So you can actually give them an example of what's moderate, because what you think is sedentary might be what your patient thinks is moderate. So give them good examples. And then down at the bottom, I loved this that was on the guideline. It said, the health benefits of physical activity are generally independent of body weight. The good news for people needing to lose weight is that regular physical activity provides major health benefits, no matter how much weight they lose or gain. So as long as they are active, the key is being active. And then they gave a great example. Adults are strongly recommended to consider walking as one way to get aerobic physical activity. Many studies show evidence that walking has health benefits and has a low risk of injury. And it also can be done year-round and in many different settings. So walking is something definitely that you can suggest your patients do, even if it consists of them parking their car at the last row in Walmart and walking more that way. Just anything to increase their physical activity. I listed a few nutrition and physical activity resources. These are all great resources, not only for your education, but also places that you can send your patients for continued education through the week, in between counseling and that type thing. All right, so the next A is agree. So as you're going through the framework and assessing your patient and assisting your patient, after all of that, they've gotten all the information, you'll want to sit down, collaborate with them. You've given them the information, you've heard them talk. So now let's both talk about and come up with realistic weight loss expectations. You'll want to agree on the behaviors that y'all need to target and talk about. Agree on treatment goals, treatment methods, as well as make sure and agree on, the fact that, you're going to follow up and stay committed. So those things are very important in the success of behavioral counseling. Okay, under agree, the first thing you'll want to make sure and do is agree on realistic weight loss expectations. Define success in realistic, achievable terms to maintain motivation. Make sure and then collaboratively select appropriate treatment goals. You'll want to share your perspective with patients on what is most important short-term goal, and agree on a target. So, for example, if your patient is borderline, glucose intolerant, and they're probably already on metformin, and we're making our way towards needing to add more medication, you might express to them, we're going to have to add another medicine that you'll have to take every day. So, in my opinion, the most beneficial thing for you to do is to try and decrease your weight and increase your exercise to decrease your A1C, so we don't have to start that medication. And in short term, you can say, so this week, can we start with exercise? And make your goals from there. And then the third thing you'll want to do is select a treatment method on the person's interest and willingness to change. First of all, you'll make sure and inform them the benefits and harm of all of the treatment options, and then make sure without a doubt that the treatment plans are realistic and they're sustainable. So, you're not going to lose 20 pounds in a day. Make sure to start out little, make short-term goals, and from there you'll be able to increase their confidence, increase their motivation, and they'll see how they feel. They'll see that they feel better. They'll see that they might lose weight. And then just take it week by week. So some important communications would be, so I believe a realistic goal for you would be to lose around 20 pounds in the next 6 months. This would put you at needing to lose about a pound a week. What do you think about this plan? And you can see the motivational interviewing skills there about how you're open-ended with your question, and you're also letting the patient advocate for themselves. So that is something that we need to teach our patients. Instead of telling them, we need to collaborate with them. Next, another thing that you could talk about would be what changes in your diet or physical activity are you willing to commit to starting to change today? So just kind of, test them and see where they're at, what they might want to do. And then you can offer a few suggestions based on what you had already told me today. So you can say, I see we've talked about these things. Can I suggest something that I think would be realistic and help build their confidence? And then lastly, you could say, I would like to walk 20 minutes. I would like you to walk 20 minutes for 5 days a week with your dog after work, and you can record your progress in an exercise diary until your next week's visit. So hearing your patient or saying that to your patient gives you a goal, an amount, and a length. So there's all these measurable things that you can say, oh, look, you successfully walked 20 minutes every day, or oh, you didn't walk 20 minutes every day, but you walked 5 days this week. So there's different things that you can use in that tactic to increase their motivation and confidence. So you'll want to use the agree portion of your assessment to collaboratively make focused goals and objectives. And you want to make SMART goals and objectives. SMART stands for specific, measurable, attainable, relevant, and time-based. If you make your goals and objectives based off these factors, you'll be much more likely to give your patient the motivation to complete these goals and to be able to move on to the next goal. All right, so moving on, the next A is assist. This to me is one of the most important parts, and it has a lot of different variables and different elements that you can bring into it. But you'll want to make sure and assist your patient in identifying personal barriers, assist them in formulating problem-solving techniques for when they run into these barriers. help them identify a plan of action, assist them in a way of making them aware of their resources and giving them information. And then assess them by giving them support, making sure that they have support at home and how to gain their support at home and talk with their family about their goals. But also, you giving them the support that they need, and teaching them how to self-monitor and how to become successful in their weight loss goals. All right, so under assist, the first thing you'll want to do is help the patient adopt and maintain an active lifestyle. And really and honestly, that is the goal of behavioral change intervention counseling, is to not just motivate them for a minute, to not, get them to lose 5 pounds and then gain 10 back. Really what it is to help them change their behavior. And so one way of talking about this with your patient would be saying, what can you think of that might get in your way of your plan to exercise 5 days this week? So, helping them assess those barriers. That's the second thing. You want to, after you ask them, what they think their barriers are for walking this week, whether it be cold or baseball games or, responsibilities, help them write a strategy or an action plan to improve their adherence. So, if their kids do have baseball games, while they're playing baseball, walk around the field instead of sitting, or, if it's cold outside, find a gym, or, find a way to increase your activity. The third thing you'll want to do is aid your patient in achieving agreed upon goals. In order to do that, you're going to have to teach them weight maintenance skills, as well as you're going to have to support them and enhance their confidence. So some communication that you can use is, how do you think you can keep on track with your goal when these obstacles get in your way this week? And we talked about that just now, about, coming up with a plan with them, and let them give you ideas, because that, if they come up with it, it's more likely to be something that they will do. You can also say, I hear you say that your interest in losing weight is a 10, but I notice that you rate your confidence as a 6. Why did you rate your confidence as 6 instead of a 1? Or on the other hand, why didn't you rate it a 10? What would help you with your confidence? So, being able to enhance your patient's confidence is huge. In a minute, we're going to talk about a scoring system, but have them elaborate on why they picked a 4, and if it's because I just don't want to, that's where you go from there. But definitely knowing what their confidence level is will help you guide them. The next thing you'll need to do is make sure and review food and physical activity diaries at the follow-up assessments. If initial goals are unmet, you may want to talk about why they're not met, or change the goals. So just to keep them, on track and motivated. You'll want to also provide resources. This is huge. You want to teach your patient how to self-help themselves. Give them materials based on interests and needs that they're interested in. Also, give them a list of local community resources, gyms, parks, walking groups, things that are different from their everyday occurrence that will help them make friends, network, find people that are also interested in becoming healthy as well. And then lastly, you want to make sure and supplement them, if they need it, with any adjunct medical treatments, such as pharmacotherapy, or, refer them for bariatric surgery. It's appropriate. If you need to refer them on to someone who can do more intense therapy, it's what's best for them. So just always keep that in mind when you're assessing their follow-ups. So some other communication that you can have with them is, how do you think your friends and family can be supportive in your journey to eating better? How could you talk to them about being your support system? So, and then lastly, I heard you talking about your dog earlier, and I wanted to give you the information on a bark park that just opened downtown. It's a perfect place to walk the dog and to walk and to play with your dog at the same time. So this is something that they're interested in. It's going to help them, do their chores, take care of their dog, but also increase their activity. So under assist, this is just the main slide, but it holds a lot of value. You'll want to utilize effective self-management support strategies in order to aid your patient in meeting their goals. And that's what it all comes down to is while you're counseling, not only are you helping them, but you're giving them the resources and tools that they need to help themselves. So that's a big thing with behavioral therapy. The 2013 ACC-AHA-TOS guidelines for the management of overweight and obesity in adults shows evidence that comprehensive lifestyle interventions usually provide a structural behavior program and include a number of components. So, after the arrow, I have listed evidence-based guideline recommendations for teaching your patient different self-management strategies. The first one is self-monitoring. There are so much research out there on keeping a food diary and activity diary. Like I said, especially at the beginning of their weight loss, evidence proves that they definitely adhere to their plan and meet their goals more consistently if they keep a journal, and also you as their provider are able to read their diary and their journal and see what they're doing and how you can help them. Also controlling or modifying the stimulus that activate their eating if they overeat. If it's stress, teach them stress modification behaviors, things like that. Also, slow down the eating process. That helps a lot. It helps their mind register that they are full and decreases the amount they eat overall. You'll want to assist them in setting goals. We talked about that. Make sure they're SMART goals. You'll want to help them with behavioral contracting and reinforcement. So when you set your goals, bring it back up. If for some reason you read their diary and they went way off the wagon, be like, hey, we talked about how we were going to agree on you doing this week. What happened? Keep them accountable, but also give them confidence at the same time. Nutrition education and meal planning is huge. Modification of physical activity, good social support, cognitive restructuring, such as you could even do cognitive behavioral type therapy interventions, and then problem solving. So helping them, advocate for themselves and learn how to manage their weight loss journey themselves as well. Assist, you'll want to provide your patient with self-help materials, give them information about community resources, teach weight maintenance skills, and identify strategies to improve adherence. There are numerous and multiple ways to do this, but one way that I have found really effective and that patients have really liked and caught on to is to utilize choosemyplate.gov. And on this slide, I have the website right here for you to click. ChooseMyWeight.gov is a comprehensive website that is provided by the U.S. Department of Agriculture for patients to learn healthy lifestyles. It has educational material, fact sheets, monitoring tools, and videos on healthy eating styles and physical activities. All of these resources are also available in multiple languages, which is amazing. So that can help with a language barrier if you have that issue at all in your practice. All right, so we finally made it. The last A is arrange. As I said earlier with the research, arrange is incredibly critical for maintaining weight loss and for helping your patients be successful in losing weight. You'll want to make sure and arrange a plan for follow-up, arrange for referrals as needed, arrange for community services and networks. So if your community does not have a lot of resources, it doesn't have a lot of places for people to go and be physically active, or to meet people that are also physically active, honestly, you can take that on as a project and make those resources. Also, you'll want to arrange group visits. Group visits are super helpful for providers in providing an intervention to multiple people, and it helps with the time management of behavioral counseling. And then also make sure and arrange follow-up, not only face-to-face, but also telephone, email, and postcard type contacts. Those are also proving to be effective in behavioral counseling. Okay, so under arrange, you'll want to first of all schedule follow-up contacts. Definitely if you're doing the Medicare, the intensive behavioral therapy, you'll see them in a week. If not, make sure and talk with your patient, see what they feel comfortable with, and have a follow-up in person. Also, if you can, if you have the resources, make sure in between your follow-ups that you at least contact them by phone, email, or postcard. And sometimes, I know that you can only do so many things as a primary care provider, but those are type things that you can delegate to office staff or to your nurses. So, but they also are very important and valuable. So part of your motivational interviewing could be make sure and mention that I want you to schedule a follow-up appointment for next Monday so we can evaluate how our weight loss plan is working for you. So give them a chance to go home, to think about things, to try things out, and see what y'all need to tweak. And then on 2, you can provide ongoing support and assistance. That's your job. That's your job as a doctor. So as a provider. So make sure and adjust treatment plan as needed. And then also just make sure and refer to nurse practitioners, to kinesiologists, to dietitians, to psychologists, personal trainers. You can't do it all by yourself, and that's the great thing about interdisciplinary care, is that we can all help each other, and we're all in it for the same goal, and that's to increase the quality of health in our patients. So like I said earlier, that's the great thing about the 5 A's framework, is that we can use it between disciplines and pick up where the other left off, and it's a great framework for chronic management of care. Something that you could talk about with your patient would be, before you leave, I would like to make sure I have a good contact number or email for you, so I can send you size tips and nutrition information throughout the week. And I believe that also in itself, not only are you going to intervene by doing that, but also that gives a great example of rapport. That gives your patient the idea that you're all in, and that you're really in to help them, and it will keep them more accountable. And then you can also say, if you would be interested, I can also schedule you an appointment with our registered dietitian next month. She can help you with diet concerns, give you recipes, or any other questions you may have. And that really, and honestly, that's their specialty. They specialize in diet and nutrition. So let them, give their expert opinion, and help you with your time management and your skills. So if you can, refer them to other disciplines. And then also, if you need to refer them to more intensive or specialized treatments, as appropriate, definitely do it. You want to do whatever is best for them. So if they do need to go and talk to a surgeon, explain that to them, explain to them why, and explain to them that you're going to have to continue where y'all left off, with your behavioral therapy, because in order to be successful in any other type of weight loss management, you have to continue your behavioral changes, or, no good will be done. So that's another thing to always think about when you're arranging things for your patients. Some communication forms could be, oh, wait, here you go. Don't forget your action plan and strategies. Make sure and bring this back next week, and we will talk about what worked and if we need to make some changes. So actually writing down their plan if there's time, and making sure that y'all go over it the next time you talk is going to help with their keeping them accountable for meeting their goals. And then lastly, you could say, Don't forget, at the checkout counter, there is a YMCA brochure with information on low-cost group physical activity. There are always classes available after 6 p.m. if you would like to go after work. So that just kind of opens up their thought process, gives them some ideas and some options for increasing their exercise. Okay, so the first thing under arrange is to make sure and schedule follow-up contacts to provide ongoing support and assistance with treatment plan. And this step, we talked about earlier, is so important, but it also is ongoing and ever-changing. It depends on how the patient's doing, the things that are going on in their life, different types of things. So this is what keeps the chronic management going is this step right here. So as you are arranging and talking and looking at your goals and fixing your goals throughout this process, make sure and think about the next 4 things. So this was according to the Canadian Obesity Network. This is part of the 5 A's Obesity Management Toolkit. These are some of the principles of weight loss, and they make so much sense, and they're a great way to encourage your patients. The first one is make sure to remember that obesity is a chronic medical condition. It is also progressive in nature, and that's what we talked about. It's going to be great sometimes, and it's going to be hard sometimes. You're going to have to change things and really just work with your patients. The next thing to remember is the management of obesity is about improving health and well-being. It's not necessarily about decreasing the number on the scale. You want to make sure that the patient is getting health benefits, but also that they're able to enjoy their life and live happily and not just always be obsessed with, calories and working out. The next member is early intervention, which is huge, consists of addressing the root cause of weight gain and finding ways to overcome those barriers. So if you skip over that and you never really address that root cause, they will continue to gain weight and it will decrease their motivation. And, you have to get down to the bottom of it. And then lastly, make sure that you know that success means something completely different to every individual. A patient's best weight may never be an ideal weight. And like I said, as long as they are getting benefits of exercise and good nutrition and they are able to live happily, make sure to encourage them not to look at the scale and make sure to remind them that, they are, even though they can't see all of the benefits, they are leading a much more healthy life by being active and healthy. Okay, so the last 2 slides I feel like are extremely important because without these last 2 slides, I don't feel like that this intervention would be conducive to using in primary care. Also, this PowerPoint, this video is super long and super detailed, but intervention should take no more than 5 to 10 minutes. And that's the great thing about this intervention. So a couple tips to help you with implementation. Shira Moore, McKinnon, and Jay in 2016 did a review the evidence and wrote an article on how to deliver high quality counseling in primary care. They show great examples of success with concrete day-to-day use of the basic components of the 5 A's model. They found that this model guides the physician to use collaborative, patient-centered approach to behavior changes while respecting the patient's autonomy, which all of those things are going to keep your patient happy, they're going to keep you happy, and you're going to see results. So under that, there is a timeline, and it kind of shows how quickly you can do this intervention. So under assess, 5 minutes at most, you want to ask your patients about weight management, diet, exercise, history of weight loss, stage of changing, and their interest and confidence. And you do not have to do this step super detailed every single time. You'll get their history, you'll get on the same page as them, and then the next follow-ups will go quicker. And then under advise, it takes about 3 minutes. You'll want to make sure and provide clear, strong advice to lose weight with personalized messages about the impact of obesity on their personal health status. Which also, at the same time, that is where you can be, talking about your comorbidities and talking about your other interventions that will definitely pop up in the middle. And then you'll want to agree and assist. That at the same time, that takes about 5 minutes. So negotiate 1 to 3 mutual goals, and address those barriers. Suggest treatments, discuss social support, and weight loss plan. And then lastly, make sure to remember to arrange, just make referrals, arrange frequent follow-up, and make sure that you're both on the same page with the care plan. Okay, so this slide is also from the same review, and it takes that really short model and kind of shows you what it will look like over time. And the hope is that providers will be able to implement the 5A's framework into their everyday practice, and it will become their second nature. It will become, the way that they assess patients. So making sure that you dedicate 5 to 10 minutes of the revisit session to discuss the diet and exercise goals. You want to give the patient their food diary and exercise log, and schedule them to come back. Or if this is a reschedule, make sure and talk with them. Use the serve or the plate method and look over what they've been doing. Assist them, even depending on where the patient is and what stage of change or what's going on in their life. Help them figure out what's going to help them be successful at that time. In the 15-minute revisit, you'll also want to make sure and spend time advising and assisting, depending largely on their confidence, interest, stage of change, and knowledge. If a patient is in that action stage and is knowledgeable, you may spend more time arranging with the patient rather than teaching them about their fruits and vegetables. So as you grow this patient-provider relationship, and as you start enabling your patient to advocate for themselves and to teach themselves how to manage their health, it will help your job become easier and help you to help them more. The bottom line is this is a long-term process, and using the 5A's repeatedly over time with each patient will definitely give successful outcomes in behavioral change. And then lastly, this is a example of the chronic care model. Overcoming deficiencies in care for chronic conditions will require nothing less than a transformation of health care from a system that is essentially reactive, responding mainly to person who is sick, to one that is proactive and focused on keeping a person as healthy as possible. Resistance to change in practice systems may be due to providers questioning the effort required and whether it will really enhance patient outcomes. Integrating behavior change counseling interventions into individual practice routines is going to require a diligent process of incorporating and maintaining evidence-based strategies and interventions over time. We cannot change the healthcare system overnight, but we can contribute to the change and at this time take the responsibility for ensuring the highest quality of care for our patients. Individually, brief behavioral counseling interventions like the 5A's framework that are feasible in healthcare settings often have only modest behavior change impacts. For example, only 5% to 15% of those patients who receive behavior change counseling as an intervention in primary care clinically make significant changes in high-risk behaviors, such as stopping smoking, decreasing drinking, or making changes in diet and exercise. Even at a population level, overall risk factors typically change only 1 to 20%. This can be unmotivational, especially given the busy primary care setting where providers can often feel as though they are putting out fires all day long and just trying to stay above water. However, we must think about this. It is so important to remember that these modest impacts translate to significant benefits in the health of the overall population when we systemically apply it to a large proportion of those in need. And not to mention the 5 to 15% of who choose to utilize provider support and change their behavior. And then here, the next few slides are my resources.